All right, so as mentioned earlier on, today's session is looking at arrhythmias in the critically ill. Really, today's specific specific subtopic is really around the basics of electrophysiology that will hopefully lay the foundation for the subsequent week's talks that are going in depth into the aspects of arrhythmias in the ICU. What we are doing in this series so far is laying the foundation of critical care medicine so that when we go into the in-depth aspects, it is easy to relate to some of the stuff we've covered here. So in looking at arrhythmias, we are taking another bite into cardiovascular medicine. In ICU, a lot of things happen to our patients who are critically ill. And sometimes arrhythmias may be the reason they get worse, may merely be a symptom of an underlying problem. And so today we just want to first understand the basic aspects of development of arrhythmias and the like. The objectives of the day, really, we hope that this session will help us understand the pathophysiology of arrhythmias and hopefully help us also just keep time as we go. In future, we shall pick out some of the common arrhythmias and dissect them to the very details that they deserve. For now, we are laying the foundation, and we hope that you keep yourselves very interested in this. The CME is also being live streamed on YouTube, and for some of your colleagues who are not able to keep on Zoom, kindly tell them to follow the CME on Zoom or on YouTube. Also, after every session, the recording is uploaded to YouTube and can be revisited. So in case there's anything from last week that you did not get clearly, kindly go back and look at the recording so that you catch up with the rest. And in case there are any questions that you didn't get the answer to, the recording might be clearer, since sometimes the internet coverage varies and we tend to lose connectivity. We also encourage you to subscribe to the channel, the AU channel on YouTube, so that you have direct alerts to any additional information that comes through that channel. So for now, I would like to let's have Dr. Joyce put up share her screen so that we get started on that particular topic. So, Dr. Joyce, could you share your screen?
Good afternoon, Dr. Erasmus. Yes, let me do that. Sorry, I'm just having a technical problem. Let me solve it. Okay, thank you. Can everyone hear me? The presentation in slide share. Am I clear? I can go ahead.
Yes,
Hello, Dr. Asmas, can anyone hear
Yes,
me?
we can hear you clearly and can see your screen. Yes, we can hear you and can see your screen.
Okay. Okay, so today we'll talk about care of the right ventricle in critical care, which basically covers right ventricular dysfunction and failure. For the last week, we did cover pathophysiology of right ventricular failure. And we also talked about the heart-lung interactions and did some cases. So hopefully you have that in the back of your mind. So for today, we'll largely look at the management of left ventricular failure in terms of clinical symptoms, investigations, and the pharmacological and non-pharmacological means of managing RV failure. So you basically did this last week, so you should know the differences between the RV and LV. It's thin-walled, or you can call it thin-skinned, largely adapted to changes. You need to know how it looks like grossly. I'm being told my internet is unstable. I hope everyone can hear me. Yeah, so how the RV looks like grossly, and you also need to understand the pulmonary circulation and how it basically differs from the systemic circulation. So the pulmonary circulation is largely low impedance and high capacitance. You need to understand the interdependence, the septal interdependence between the RV and LV, and things that can change it, and eventually coronary perfusion. These were all talked about. So the RV is not just timid, it's wonderfully and fearfully made. Again, from the pathophysiology, we talked about how abnormal preload or reduced contractility or unaltered rhythm or increased afterload, or even how altered interdependence can affect the function of the RV. So basically, this is the most important slide, because when it comes to the diagnostics and the management, we basically stage all those things based off these 5 characteristics. So of course, RV has been treated as a side chick for so long, but in critical care, you need to be, of course, very careful with it, because it's an important cause of hemodynamic instability, like we saw last week with 2 patients who had one with a massive PE and the other one with a right myocardial infarction. RV dysfunction can also occur as a consequence of an ICU admission based off the interventions that you do when you're managing patients in the ICU, and of course it's a common consequence of cardiac surgery. So when you're working in a coronary unit, there's some patients who will admit with pre-existing RV dysfunction, so those are at risk of failure. We also know that ARDS, which is a common cause of ICU admission, leads to RV dysfunction in an estimated 25 to 50% of the patients. And of course, it affects prognosis. So as a person in the ICU, you need to be able to understand it. So the causes of all the risks of RV dysfunction and eventually failure in the ICU can be categorized in the 4 things that we talked about. Things that can acutely increase our afterload. We know acute pulmonary embolism, a massive pulmonary embolism can do that. ARDS also does that acutely. And we know how your positive mechanical ventilation will alter, can affect your RV dysfunction and how it improves LV function. For contractility, of course, you have an RV myocardial infarction, but you also have cardiothoracic surgery, insertion of LV devices. Other things include LV dysfunction, or LV systolic dysfunction. Things that the other things that can affect your afterload are things that affect pulmonary vasoconstriction. So the hypoxia, hypercarbia, and atelectasis. And then also there are some patients with pre-existing pulmonary hypertension. That's for one reason or another. Then other things like sepsis can affect your preload. So acute RV dysfunction, the definition is loose, but basically you describe acute RV dysfunction as a change, a change in any one of the any one of these parameters. One, a change in your RV systolic dysfunction, we'll see how to measure that, or an increase in your nitropeptides, and this and an ECG RV strain pattern are not really specific. And so is the increase in troponins. But basically, RV systolic dysfunction is when you're starting to have features of RV systolic dysfunction, which is largely measured on echo. So you get acute RV failure if you have signs of acute RV dysfunction with a low cardiac output and signs of hypoperfusion. So this eventually leads to backward pressure and forward pressure, like we discussed, and the various symptoms in those categories. So acute copulmonale is basically defined as a RV dysfunction due to an increase in afterload, an acute increase in afterload. So the clinical symptoms basically depend. When there's backward failure, that essentially leads to systemic congestion. So you're basically going to get elevated CVPs and JVP, which is what you see is a CVP you'd measure. So you'd get peripheral edema, ascites, you can get AKI, hepatic dysfunction, and even GI dysfunction. That's from backward failure. Again, my colleague elaborated very well how this happens. Then from forward failure, when you get especially an increase in right ventricular end diastolic volume, and that affects the septal interdependence, you end up affecting LV filling, and that leads to hypotension, later on shock and MODS. So the investigations, apart from the other preliminary investigations, the ones that you can do in shock, like the lactates and every other thing, I specifically went to how you'd investigate RV dysfunction. The most sensitive measure, we use an echo because it's largely available and not invasive. So echo, ECG, of course, a pulmonary artery catheterization is quite invasive, but you can also use a cardiac MRI. So there are parameters that you look for on an echo that signify RV dysfunction. So there are structural parameters, then there are functional parameters, just basically functioning, meaning either systolic dysfunction or diastolic dysfunction. And then there are parameters that measure RV afterload, that do an RV afterload assessment. Although these are not as accurate, the most accurate measures for RV afterload assessment, of course, are pulmonary catheterization. So with RV structure parameters, you'd measure the basal RV diameter, which is around the tricuspid annulus. You can measure that RV diameter. You can also measure the mid RV diameter. You can look at the ratios of, that's the right ventricle end diastolic diameter, and compare that to the LV end diastolic diameter. You can also look at the RV wall thickness if it's more than 5 millimeters. And then McConnell sign, those are the ones I'll largely talk about. And then there are the parameters that measure RV function. So you remember when we're being told that the RV largely has longitudinal contractility. So the TAPS is what I will largely focus on. The parameters that measure RV afterload, that do RV afterload assessment, largely via Doppler. So of course, we know that cardiologists are very interested in numbers, like you've seen. But when we are doing POCUS, especially in the emergency room or in the ICU, we largely base on fractions. So I'm largely going to focus on talking about your findings on POCUS. So on POCUS, we'll measure the cavity size, the size of the cavity of the RV, and largely we do a comparison. We compare it to that of the LV. We look at the shape of the septum. We look at longitudinal shortening, that's measures systolic dysfunction. We look at the change in cavity, that's from the end of diastole to the end of systole, and then we look at we can also look at meconial sign. So the cavity size is usually done with a 4 apical chamber view, and basically what you're looking for is that the size of the RV. Like I said, there's this the basal diameter of the RV should be about 4.2 centimeters. So it's the basal diameter is here where the tricuspid annulus is. But you should also be able to eyeball it and see the RV should largely be about 2/3 of the LV. It should not be bigger. And of course, the LV is the septal ventricle. So that when you're comparing, the apex should largely belong to the left ventricle. So that's how you can compare the two diameters. Then we look at the septum. If you look at the image on this end, you see that the RV is dilated. It's bigger, essentially bigger than the LV, and it's basically taking up the apex of the ventricle. We can talk about the shape of the septum. So the septum largely should fall, and this is done in the short axis view, the parasternal short axis view. Largely, the septum should be circular, both in diastole and systole. And of course, you know the LV, the cavity of the LV is always bigger than the RV. So when you're doing this view, you should be able to see a circular septum with it bulging into the cavity of the RV. If the septum is largely flat, forming like a D septum, that shows you that there's largely either pressure or volume overload. So with volume overload, you may largely see a flat septum in diastole, but with pressure overload, you see a flat septum in both systole and diastole. When we move to TAPC, which is tricuspid annular plain systolic excursion, you know that the LV contracts longitudinally. So at the end of diastole, the cavity is big, so it's big and long. And at the end of systole, after the ejection, it will shorten and move towards the apex, which is right there. So the tricuspid annular basically measures the distance between the apex and the base of the right ventricle. So the distance at the end of the difference between this length at the end of diastole compared to that at the end of systole should be at least 21 millimeters. So when you measure that distance, like the one you get at the end of diastole compared to the one that you get at the end of systole, it should be about 21 centimeters. So if that distance is less than 1.5, then you know that there's probably RV, systolic dysfunction. Also, you can compare the same distance in the left ventricle. So the one of the right ventricle should largely be twice that of the left ventricle. So if they're equal, or the one of the left ventricle is bigger than that of the right ventricle, then you know that those are signs of RV systolic dysfunction. The other measure is the change in cavity, size from systole to the end, from systole to diastole. So the cavity of the right ventricle should change by about 1/3. from end diastole to end systole. So that's also another measure to show diastolic dysfunction. So the last sign is McConnell's sign. That is not very sensitive, but it largely measures regional wall RV dysfunction. So if the RV wall is hypokinetic, so it's not, in other words, it's not moving well, then so that's McConnell's sign. Usually because of the different blood supply, the apex and the septum are usually functioning well, but the RV free wall is not functioning well. So those are the 5 signs that I've listed there, the ones that you can get on POCUS. The other investigation that's done is a pulmonary artery catheterization. Again, it's quite invasive. It's done largely as a monitoring tool in places where it's available, especially in cardiac ICU. So the diagnosis of RV dysfunction or failure does not necessarily warrant you doing a pulmonary artery catheterization, but you can do it when a patient has a severe RV dysfunction on echo. And the parameters that you largely see, you see an elevated central venous pressure. Usually the index between the CVP and the pulmonary capillary wedge pressure is more than 1. And then you also see a low cardiac index, it's less than 2, and a low stroke volume index. So you can use it as a parameter, especially when you're doing goal directed therapy, giving you fluids and things like that. The other one, largely on the signs on ECG are not specific, but you basically see signs of RV strain or any other signs of pathology. For instance, when there's an MI, you see ST elevation in the appropriate leads, or signs of a PE. The other blood work is largely the cardiac markers and the peptides. So the management of RV dysfunction in the ICU largely starts with prevention. You need to be able to identify patients who are at risk. Maybe someone has pre-existing pulmonary hypertension. You need to be able to treat any underlying causes or triggers. Yeah, so for instance, if a patient has a massive PE, you know that you need to prevent any triggers that will exacerbate the pulmonary hypertension. So if these patients have ARDS, or if you need to ventilate them for any other measure, first of all, it's good to consider non-invasive ventilation if that can be done and if it's appropriate. And when you do ventilation, you need to do ventilatory measures that basically RV protective, to have an RV protective ventilator strategy. So that basically includes having the appropriate PEEP, having a relatively low tidal volumes. Your plateau pressures should largely not exceed 27, and your driving pressures should also not be more than 18. Of course, in ARDS, sometimes you do permissive hypercarbia, but that should not exceed 60 millimeters of mercury. And essentially, with these patients that may have ARDS, you may prone, not necessarily for refractory hypoxia, but just in protection of a patient with RV strain, so that you can equally distribute your positive pressures. Be kind, of course, be kind to your lungs and then your RV. Yeah, rather than waiting to prone the patient when there are signs of refractory failure, you should have hypoxemia should probably prone earlier as a preventative measure. So in management, the management principles are largely to reverse any, of course you start with ABC, but largely to reverse any cause, any acute cause that you can, to do preload optimization, prevent any increases in afterload, improve contractility, and improve perfusion. So this is just a schematic. So when you diagnose the RV failure, it's good to first, any treatable cause. So a massive PE should be thrombolized, just like you may need to do PCI and in case you have an RV infarct. So if that treatment is successful, then you just largely monitor RV function. But if that's not successful, then you may need to do other supportive measures as you recover. So like we talked about, you need to optimize preload. Both hypovolemia and hypervolemia are bad for the RV, so you need to be able to optimize your preload. You need to be able to treat anything that creates excessive afterload. So treat any factors that cause hypoxia, acidemia, and any abnormal lung volumes, or things that will alter your heart-lung interactions. The pulmonary vasodilators are basically used as last line. You need to be able to improve perfusion such that you don't affect coronary perfusion. So you need to reverse systemic hypotension, decrease any RV wall tension, and you can do this with pressors. Then you need to increase cardiac contractility if there are any issues affecting contractility, and maximize your myocyte function. So treat sepsis and treat anything that can affect metabolic abnormalities. Of course, you know, these don't only affect the heart, but they also can end up affecting the lungs. And if all these measures fail, then you may end up considering a form of mechanical support. So for preload optimization, like I've said, both hypovolemia and hypovolemia affect RV function. You need to be very careful with the amount of fluid you give, especially in people who have increased afterload. And you should ideally do goal-directed therapy. So largely give some boluses of fluid, and then assess how they have affected all the other parameters. In other words, you need to assess fluid responsiveness, although the dynamic parameters in RV failure are largely inaccurate. That is, the SSV and the PPV are largely inaccurate. For fluid boluses, we'd usually give fluid, especially if your CVP is between maybe 8 to 12, you can give some fluid, and your SVO2 is largely below 60, but you need to monitor that and also monitor for signs of RV dysfunction. So if there are signs of fluid overload, then you may need to give diuretics, and if there's largely you start with a loop diuretic. If there's any diuretic resistance, then you may need to add a thiazide diuretic. If the patient has a AKI and is not passing urine, then you need to consider a proper form of dialysis. So for afterload, avoiding excessive afterload, you basically need to treat any trigger of any trigger causing that excessive afterload, and prevent hypoxic pulmonary vasoconstriction. And we said, we need to have lung protective strategies. The pulmonary vasodilators are largely a last resort after all the other things we've talked about have failed to work. The other measures we're going to talk about, but largely you need to also remember that if the pulmonary hypertension is from fibrosis, it's long term, then some of these measures may not work. So the best pulmonary vasodilator is one that is localized, so it can act locally rather than systemic, because if they're systemic, that means they'll cause hypotension and worsen coronary perfusion as well. So they need to be localized, and they should largely be short acting. So nitric oxide, which is inhaled, has a short onset, is largely preferred over the others. But there are also some prostacyclin derivatives like iloprost that are used. And the good thing is that they are inhaled. They're largely inhaled. The place of other phosphodiesterase inhibitors, of course, is still doubted, but they can they have a place in combination with nitric oxide. But like I said, they're usually last resorts. The phosphodiesterase inhibitors are like, for instance, sildenafil, which is the commonest. So improving of perfusion and contractility. One, in patients with severe pulmonary hypertension, you need to know that the RV systolic pressures are usually high. So you need to be able to maintain good systemic pressures in order to avoid hypoperfusion and to avoid that cascade of then hypoxia and worsening contractility. So to improve your blood pressure, you basically use a vasopressor, and if you need something for cardiac contractility, then you largely use an inotrope. So of course the best vasopressor is one that can the best vasopressor, of course, is regarded as noradrenaline, but then its effects are dose dependent. To get rid of this, but I failed. So noradrenaline, of course, acts largely on alpha-1, so it's able to give you systemic vesicular resistance, and it has some effect on beta-1 as well, but largely it's able to improve your blood pressures and may not does not affect your pulmonary does not cause a lot of pulmonary vasoconstriction, and if you use it in the right doses, it may not give you a tachycardia. So if it gives you, of course, a tachycardia, that can worsen your RV contractility, so it is the best. Vasopressin can also be used in low doses. It can increase your blood pressures and has minimal effect on the pulmonary vasculature. Phenylephrine is bad in this instance because of its effects on it increases pulmonary hypertension, so you want to avoid that. The best when it comes to inotropes, dobutamine can be used. Of course, it largely acts on beta-1. It has good pulmonary vasodilatation, so it improves the RV pulmonary coupling. However, sometimes it's associated with tachycardias and arrhythmias, so it can be counterintuitive. The other inodilators, Mirinone, which is a phosphodiesterase inhibitor, is good at increasing myocardial contractility with minimal effects on your heart rate, so it can be better than dobutamine. And then there's levosimendan, which is a calcium sensitizer. Basically does not increase oxygen demand, so it's very good for in MIs when you have RV myocardial infarction, to increase your contractility. Epinephrine has its obvious effects. It's not specific, and it's the same problem with dopamine, although of course with dopamine it's more dose dependent. So those are largely last resort unless there's any other indication. So you know that rhythm largely affects your atrioventricular asynchrony and your atrial kick. And also sometimes patients with RV dysfunction will come with other comorbidities, complications like maybe RV, like maybe atrial fibrillation or atrial flutter. So it's good to avoid tachycardias or arrhythmias. So if you have a tachycardia and you're hemodynamically unstable, you might end up having to do cardioversion. But also if you have a severe brady, like in MIs, you might end up having to insert a pacemaker, like what presented to. So in last resort, after most of these measures have failed, then you might have to use either a lung assist device if it's available to you. This usually will pump blood from the right atria to the pulmonary artery, or you might have to use ECMO, either veno or veno arterial. Yeah, that was the presentation. Thank you.
This was the talk that we not cover last week due to the issues. So this has been the talk on the care of the right ventricle. We have got just a few questions. Okay, one question on the chat. For those who haven't yet raised their questions, you can type on the chat or you can raise your hand. So Dr. Joyce, the question we have from Moses Arenitwe is, why do we do permissive hypercarbia RV dysfunction? Because I thought permissive hypercarbia worsens hypoxic pulmonary vasoconstriction, which worsens pulmonary hypertension and increases RV afterload. What a good question there, Arene.
Okay, thank you, Dr. Asma. So I think sometimes you can be caught between a rock and a hard place. My imagination is if you have a patient with ARDS and they have RV dysfunction as well. So you're torn between you have to do, of course, in ARDS, one of the strategies to improve oxygenation is to do a bit. The strategies that you do to improve oxygenation sometimes will affect will cause hypercarbia. So unlike other patients with ARDS that may have a normal functioning RV, you might have to sort of reach a middle point. So from the literature I was reading, they gave a value. They didn't give a pH, but they gave a value of a PaCO2 of about 60 millimeters of mercury, that you shouldn't go beyond it. You should not have, of course, hypercarbia increases after load, but in a patient where you have two comorbidities at the same time, you might have to compromise and hit middle. Thank you.
Yeah, that's a very good answer, Joyce. So Moses, you know, it's about the relative effect of three things on the pulmonary vasculature. One being oxygen, which you're hoping to improve by permissive hypercarbia. In other words, you're trying to maximize the oxygenation of the lung and therefore oxygenation of the blood. And that has got an effect on the pulmonary vasculature directly through the PaO2, the alveolar oxygen tension increasing, which directly also causes pulmonary vasodilatation, as well as the arterial oxygen tension improving, which might also cause pulmonary vasodilatation. Now that is matched versus the increase in PaCO2. But at the same time, you have to remember that the efforts you make to try to clear CO2 from the body involve using dangerous ventilatory efforts, which might in the end, might dilate, hyperdistend already restricted lung volumes, and also might cause more damage to the rest of the lung, causing ventilator-associated lung injury. And these two directly worsen pulmonary vascular resistance. So it's going to be a balance between trying to improve oxygen versus preserving the lung long enough. There are some studies that have been done where they're looking at what amount of CO2 might be intolerable And honestly, the number is so low. It's about, I said, Dr. Joy says it's about 60. I found about 70. The truth is, by the time we're even thinking about going for permissive hypercapnia in most of these patients, they are already in that zone of 60, 70 or so. So by the time you do permissive hypercapnia, you're already looking at going even higher in the CO2. So the ideal way of taking care of the right ventricle in this situation would be to put the patient on either ECMO or extracorporeal carbon dioxide removal, which is another extracorporeal device to remove CO2 while you reduce the ventilating pressures and volumes to protect the remaining and viable part of the lung. That would be the approach taken. All right, but good question there, Naitwe. Any other question, guys? All right, so I would like to draw a curtain to that topic of the right ventricle. We set out to make sense of the people's ventricle, and that's what we've been discussing in the last session and this last talk that Joyce has given us. And the important lessons to take home here are that you must understand the comparative anatomy and physiology of RV and LV if you're to care for the right ventricle well. You must be able to interpret the biological mechanisms of RV failure and use the physiology to elucidate the cause of distinct mechanisms, that is pressure loading, volume loading, and ischemia, that you need to be able to understand and delineate. The right ventricle can screw you over because so many things affect it. There is this particular correlation with the pulmonary disease. We shall probably be tackling this again when we're looking at pulmonary physiology, stroke pathophysiology, the ICU, and there are different grades of dysfunction RV. With the progress of pulmonary disease, we'll get to understand a lot more how important the RV is and whatever we do in critical care medicine. In evaluation, Dr. Joyce has done a very good job here as in the assessment. I just wanted to point out important questions to ask when you're doing an echo. You want to see the RV dilated. Is there systolic dysfunction? Is there diastolic dysfunction? Do these dysfunctional changes appear acute or chronic? And is there pulmonary or tricuspid valvulopathy, the right side of the pressure? So this is what usually the echocardiographer determines during the assessment, but you can do the same assessment of point of care ultrasonography, especially if you have got a bit of more advanced device bedside to be able to measure a number of things. So once you have this information, you're kind of ready to go. Something that we don't do very well is that RV can fail because of the RV can fail because of pressure loading, and they so I will challenge especially the fellows to go and look up the distinction of the two. So right here is my final slide on that talk on the. You have to remember it's supposed to be stepwise, but you're doing almost everything at the same time. When the patient presents with RV dysfunction, you want to manage the substrate in terms of reversing the trigger, whatever triggered the RV failure, and then also take care of that aggravating factors. For example, the patient might have got a trigger from ischemia, which you need to reverse by revascularization, but acidosis from hypoperfusion might aggravate the problem and continue driving once it's a perfusing function. You definitely have to find that soft ground between preload, between afterload, inotropy, and restoration of perfusion of tissues. Unfortunately, the outcomes for patients who go on mechanical assist tend to be very dismal, and perhaps this is because most times we go for ventricular assist therapy as a last ditch or salvage therapy, And usually they're talking about putting a dying person on a good machine. They will be dead anyways. So this is really why the data is not very, very good for patients who go on this. But at the same time, we are still struggling with what exactly the trigger should be for us to move to mechanical assist therapy. But this is to do with ECMO. In the case of RV failure, you're really talking about doing VA ECMO. That's veno-arterial ECMO, where you take off blood from the venous system, oxygenate it, and then pump it retrograde into the aorta. There are also other assist devices, but probably they're acute and quick. We've got the RVADs and so on, which are really a little bit more difficult to put in. They need to go to cardiac theater to be placed. And these are not yet in our setting. So the idea is to restore and improve right heart hemodynamics and maintain a perfusing blood pressure, as well as an adequate cardiac output for organ function. So this is not done in isolation. You have to do it while supporting other organs to the neurological system, GIT, other things, because in the end, the organism must survive. So thank you, Dr. Joyce, for concluding that area. I would like to move us to the next part, and probably the meal of the day, which is arrhythmias in ICU, and the objectives of this particular series is going to be to help us understand the pathophysiology as well as the pharmacotherapy of arrhythmias. Later on, as we carry on, we shall kind of get to understand a bit more about the common arrhythmias we get and how we go about treating them, preventing them, among other things. So today's talk is really basic science based. It's really going to be helping us wrap our heads around the electrophysiology behind cardiac activity and dysfunction. It's called arrhythmias. So we shall have a talk on cardiac electroactivity, physiology, and arrhythmic drugs. Today's session will mostly be presented by residents but each resident has got a mentor who is one of the fellows of our critical care program. So without taking much time, university, she will be taking through cardiac electrical activity. She will be mentored by Dr. Waswa.
Am I the only one who is having problems hearing Erasmus? Erasmus? I think we have lost Erasmus. All right, I think he had introduced Dr. Lynn Mather Natari, and she's an anesthesia resident in Higher 2. And he mentioned that she has been mentored by Dr. Peter Waswa. And so at the end of this session, the two of them will be taking some of the questions. So as Dr. Lynn Mather prepares, I'm going to launch a poll question to allow us to be able to try to see if we are aware of the cardiac electrical activity. So here's a poll question, and we shall take about 3 minutes to respond to it. There are about 6 questions, all related to some bit of knowledge on cardiac electrical activity. So if you can't see the poll question, please let me know, and then I'll see if I can guide you on that. But it should pop up on your screens to allow you to be able to respond. For those who are co-hosts, you can still look at the poll question if you go to the polls and quizzes bar and tap that. You may not be able to respond, unfortunately. This is for the rest of the audience. Some of the questions are, you can select more than one option because there may be more than one option that is correct. For some of the question, only one answer is the most correct. So select the one. For those that have more than one answer that is correct, they have select all that apply in the brackets at the end of the question. Those that only have one most appropriate question do not have that in the brackets. So that's how you know the difference. We've taken about 1.5 minutes. We have another 1.5 minutes to answer the question, and then we'll close the poll. So for those who are co-hosts, please, you can look at the polls if you're interested, or we can always discuss them at the end in case you can't see them. Okay, we have less than 1 minute, and then we shall close the poll. Now I have less than 30 seconds, and then I'll close the poll. So in case you're still answering, try to submit as soon as possible, and then we'll discuss this at the end with the results of the audience responses. Okay, I'm going to close the poll in a few seconds from now. All right, the poll is closed. Dr. Martha, please, the floor is yours. Thank you.
Good evening, everyone.
Good evening. We can hear you.
Okay. Natalie Lynn Martha, IR2 resident, Macquarie College of Health Sciences, Anesthesia Department. And today I'm going to be talking about cardiac electrical activity. So I'll get right into it. Can you see my slides?
We can see your slides, please.
So we know that the primary function of the heart is to pump blood into the circulation, and the heart is a muscle that is composed of different types of cells. So we have the myocytes, which are the fast conducting cells, and transmission of these electrical impulses depends on the characteristics of the cardiac cells. That's ability to spontaneously initiate an impulse, this ability, and then the thoughts from ion shifts across the cell membrane and indicates how well a cell responds to an electrical stimulus, so the ability of a cell to transmit an impulse to another cardiac cell. And lastly, contracts after receiving a stimulus. So cells are excitable, but non-contractile.
Dr. Martha?
Sites are capable of both and like brain potential.
Hello, Dr. Martha. I'm sorry, your
Yes?
internet is fluctuating significantly and you're breaking up too much. I'm going to request your mentor to send me your slides, and then I'll probably project them from my side, and then we go through them as we speak. It's probably something to do with the bandwidth. So if you can proceed for now, Dr. Peter Ashworth, please email me those slides so that I can share them from this side. Otherwise, try and proceed as I get those slides.
Okay, so as I was saying that the resting cell membrane has a higher permeability to potassium than sodium, and that's largely due to the inward rectifying potassium channels. And these channels are largely open at negative membrane potentials, but they close with depolarization. So usually potassium diffuses down its electrochemical gradient, which results into the interior of the cell becoming negatively charged with respect to the exterior. And this resting membrane potential varies depending on the region in the heart. So for example, in the SN node, the resting membrane potential is around negative 50 millivolts. And in the atrial myocyte, it's about negative 70. In the Purkinje fiber, it's negative 90 millivolts, and the ventricular myocyte, it's about negative 90. So when we talk about the pacemaker potential, this basically refers to a spontaneous decay of the membrane potential of a pacemaker cell from a membrane potential of around negative 60, that's in the SN node, to a threshold potential of negative 40. And this is where the action potential is initiated. So the rate at which this decay occurs determines the heart rate. And this is the property of the pacemaker cells that is called the automaticity. So when we look at this pacemaker potential graph, we see that the action potential in the pacemaker cells includes contributions from the HCN channels. Those are the hyperpolarization activated cyclic nucleotide gated channels. And these channels are permeable to sodium and potassium. So when an action potential is initiated, there is membrane hyperpolarization, which opens the HCN channels, as you can see here. And this allows the sodium and potassium to diffuse along their electrochemical gradients. So the overall sodium influx will slightly exceed the potassium efflux, which will result into a slow depolarization of the cell membrane from its initial voltage of negative 60 to around -50 here. So when the pacemaker potential gets to around -50, there is opening of the transient type calcium channels in the pacemaker membrane. And when they open, we have an inward influx of calcium currents from the extracellular fluid, where they have higher concentration, to the intracellular fluid, where it's of low concentration. And this inward movement of the calcium ions will enhance the membrane depolarization to around a threshold potential of around -40. So once the pacemaker cells reach the threshold potential, then an action potential is initiated, and this level of depolarization goes up to around +20 millivolts. And at the peak, we have the HCN and the calcium channels closing, and the voltage-gated potassium channels open, which initiates the wave of repolarization back, and then this cycle continues. So this is a bit different from the action potential in the myocyte, which has 5 phases. And phase 0 is a phase of depolarization, when the cell receives an impulse from a neighboring cell and it's depolarized. Then phase 1 is marked by early rapid repolarization, which is a period of slow repolarization. And during phases 1 and 2, and at the beginning of phase 3 here, we have what we call the absolute refractory period. So during this period, no stimulus can be able to excite the cell, however strong it might be. So we said phase 3 is a phase of rapid repolarization as the cell returns to its initial stage, and then phase 4 is the resting phase. So towards the end of phase 3, we have a relative refractory period, and during this period, a strong stimulus is able to excite the cell. So going deeper into the cardiomyocyte action potential, what actually happens at the different phases that I've just described. So normally the threshold potential for a cardiac myocyte is around -65 here. So this -65, as we see, the resting membrane potential is -90, but the threshold is -65. So this threshold potential is reached by the local currents that are conducted through the gap junctions from the neighboring myocytes. And stimuli that exceed that threshold potential can trigger the opening of the first voltage-gated sodium channels and increase the membrane permeability of sodium. So the resultant increased sodium influx will cause further membrane depolarization. And once this happens, further opening of the voltage-gated sodium channels will happen, and it's a whole positive feedback mechanism. And this ends up in a rapid depolarization to around +20 millivolts, as you can see in the curve here. So following this depolarization in phase 0, the voltage-gated sodium channels will become inactivated, and then there is a rapid decrease in membrane sodium permeability. And we also see that the first voltage-gated potassium channels close, and the slow delayed rectifier potassium channels open. So all this causes a brief phase of repolarization, and that is what we call the phase 1 of that action potential. Then phase 2, which is the plateau phase, following the early repolarization phase. So membrane depolarization will be maintained for a prolonged period of time. That's about 200 milliseconds. And this is maintained through a balance of currents. So there are inward currents and outward currents. So the inward current is the voltage-gated L-type calcium channels will slowly open following the membrane depolarization, and calcium ions will flow down their concentration gradient from the extracellular fluid to the intracellular fluid, where they are of low concentration. So the outward current, on the other hand, is via the inward rectifying potassium channels, which are predominantly responsible for generating the resting membrane potential, like I mentioned earlier. But these close following membrane depolarization. And at the same time, the membrane depolarization will cause the slow delayed rectifier potassium channels to open. So overall, there is a net inward current that maintains that plateau of phase 2. And then in phase 3, which is the repolarization phase, we have a gradual inactivation of the voltage-gated potassium channels that opened here. And this reduces the inward current of the calcium ions. And there is an additional outward current of potassium that returns the membrane to its resting membrane potential. Just as we see here, that the potassium channels open, and the first delayed rectifier potassium channels will also open, and the L-type calcium channels close off. Thus, the membrane returns to resting membrane potential. And then on top of all this, because there has been an exchange of all these ions, sodium, potassium, and calcium, there are other players that also help in correcting the net fluxes. So we have the sodium, potassium ATPase, and the sodium calcium exchanger. So then we'll move on to the regional variations in cardiac action potentials. And we see that various types of cardiac tissues have different ion compositions, and this brings about the regional variations in the cardiac action potentials. So if we're to start from the sinus node, whose action potential we saw as the pacemaker potential, we see that it's characterized by phase 4 depolarization, which gives rise to its pacemaker activities. So this phase 4 depolarization is due to a high density of the pacemaker current and the lack of a strong inwardly rectifying potassium current. And this also accounts for the relatively depolarized state of the tissue. Because remember, the resting membrane potential of the pacemaker cell is around -50 to -65 millivolts. So in addition to that, sodium channels are also sparse. So we see that the action potential upstroke is slow because it's mediated by the L-type calcium current, and there is no discernible phase 1 because of the lack of a transient outward potassium current. So these action potential durations are short, and the frequency of depolarization is determined by the parasympathetic and the sympathetic modulation of the pacemaker current and then the L-type calcium current. So when we move down to the atria, which is the second curve, we see that at least for it, it's a bit similar to the curve that I've just described, the general curve that I've described for the action potential of the cardiomyocyte. So in the atria, the action potential has rapid upstrokes, which we see here, which these allow for the electrical impulse conduction from the right atrium to the left atrium, and then also from the sinus node to the AV node. And it has a discernible phase one, unlike this, which was not discernible. So here the phase one is discernible, and it's followed by a short plateau phase and a rapid repolarization. So this short plateau, it is a ultra rapid delayed rectifier potassium current, as well as the transient outward potassium currents. So normal atrial tissue has no phase 4 activity due to the presence of a strongly inward rectifying potassium current. And if we are to move down further to the AV node, we see that its action potential, because it has pacemaker activity, it's almost similar to the one in the sinus node. So this is because of the lack of the sodium current and the potassium, the strong inwardly rectifying potassium current. And conduction through the AV node is still mediated by the L-type calcium current, just as the sinus node, and the propagation is slow. And this accounts for its decremental conduction properties, because we see that it conducts at a slower rate than the SN node. So the L-type calcium current is significantly activated by sympathetic stimulation, and it's inhibited by the parasympathetic influences. And these are important determinants of impulse transmission through the AV node. And the phase 4 depolarization in the AV node is usually not as prominent as in the sinus node. Then when we move down to the His-Purkinje fibers, that's the fourth curve, we see that for them, they have a high density of sodium current, and this facilitates the rapid conduction of impulses so that the ventricular myocytes can be activated synchronously. Because as we shall see, these Purkinje fibers are divide to the right and left ventricle into the endocardium. So
Hello, Martha, are you still there? We can't hear. I don't know if it's me, but we can't hear much. Anyone else who can't hear her?
Can't hear her.
okay.
All right. Let me share from my side.
Hello?
Martha, you can proceed. I will just go through the slides when you're done with this, you let me know to move to the next.
Okay, just give me a minute. So I do not know when you last had me. Where did you stop hearing me?
I think you had moved to the part of the ventricles. That's where you are.
Okay, so as I was saying, in ventricular myocytes, there are the densities of the sodium current and strongly inward rectifying potassium currents are much higher than in the atrial myocytes. And so these cells rest near negative 90 millivolts and electrically quiescent. So the configuration of the action potential varies according to the location in the ventricle. So we can see we have three different curves there, one for the endocardium, the mid-myocardium, and the epicardium. So the epicardial layer has very strong transient outward potassium currents, and this leads to a marked repolarization phase 1, followed by depolarization as the calcium currents are activated. And this generates a characteristic spike and dome. It's very clear. If you look at the curve for the epicardium, there is that very high spike and then it comes down. It's a bit different from all the other curves. So in contrast, the endocardial layer has a much lower density of these channels, and it has a reduced phase 1 amplitude and no spike and dome. You can still look at the endocardium curve. And then the mid-myocardial layer has what is called the M cells. And these have strong transient outward potassium currents, but weak delayed potassium rectifier currents. And so they have a slow component of voltage-gated sodium currents. So the M cell action potential also has a spike and dome configuration and a lengthened action potential duration, which exceeds the one for the endocardium and the epicardium. As you can see for it, it's going a bit longer on those graphs. Next slide. I'm not sure what I'm seeing. Okay, so those electrical impulses are transmitted around the heart by a special conduction system, which is made of the sinoatrial node, the AV node, the His bundle, and the Purkinje fibers. So if we are to start from where this conduction system begins, we have the SN node, which is located in the upper right corner of the right atrium, where the superior vena cava joins the atrial tissue mass. So it's the heart's main pacemaker and generates impulses at rates of about 60 to 100 times per minute. So when these impulses are initiated, they follow a specific path through the heart, as if you're able to follow the drawing. And these impulses can non-flow backwards because the cells respond. The cells cannot respond to a stimulus immediately after depolarization, as I previously described the absolute refractory period. So impulses from the SN node will travel through the Bachmann bundle to the left atrium, and then through the internodal pathways and the middle and the posterior internodal tracts. So impulse transmission through the right and the left atria occurs so rapidly, and thus the atria contract almost simultaneously. So once the impulses are transmitted to the AV node, this AV node is located in the inferior right atrium, which is near the ostium of the coronary sinus, and it is responsible for delaying the impulses that reach it. So although the nodal tissue itself has no pacemaker cells, the tissues surrounding it, which we call the junctional tissue, contains pacemaker cells, and these fire at a rate of 40 to 60 times per minute. And the main function of the AV node is to delay impulses by 0.4 seconds. And this delay helps to keep the ventricles from contracting quickly. And it also allows the ventricles to complete their filling phase as the atria contract. And additionally, it allows the cardiac muscle to stretch enough as it prepares for cardiac output. So from the AV node, we have his bundle, which is a tract of tissue, and this extends into the ventricles next to the interventricular septum, and it resumes the rapid conduction of impulses through the ventricles. So this bundle will divide into right and left bundle branches, and the right bundle branch will extend down to the right side of the interventricular septum and through the right ventricle, as you can see in the diagram, and then the left bundle branch will also extend down the left side of the interventricular septum through the left ventricle. So the left bundle branch further divides into the left anterior fasciculus, which extends through the anterior portion of the left ventricle, and the left posterior fasciculus, which runs through the lateral and the posterior portions of the left ventricle. So impulses travel much faster down the left bundle branch than the right, because the left bundle branch feeds the larger and thicker-walled left ventricle, while the right side or the right bundle branch feeds the smaller and the thinner-walled right ventricle. But this difference in the conduction speed will allow both ventricles to contract simultaneously. So this entire network of specialized nervous tissue that extends through the ventricles is called the Purkinje system. And these Purkinje fibers extend from the bundle branches into the endocardium, which is deep into the myocardial tissue. And they conduct impulses rapidly through the muscle to assist in its depolarization and contraction. So these Purkinje fibers can also serve as pacemakers and are able to discharge impulses at rates of about 20 to 40 times per minute. But sometimes they discharge more slowly than that. And it is important to note that these fibers are usually dormant. They are not activated as pacemakers unless conduction through the bundle of His is blocked, or there is a blockage from the SA or the AV node, or no impulse is generated from the SA or the AV node. Next slide, please.
Well, please wrap this up in 3 minutes.
Okay, almost done. So the electrical events that are happening in the pacemaker and the conduction system are represented at the body surface by the ECG, and it is a result of differences from electrical potentials that are generated from the sites of the heart from each membrane. What we
Lynn Martha, we still can't hear you. The network needs to be adjusted. But I think we've run out of time for this one. And she had a few slides left regarding ECG, and I think we can call it off for now, and we'll probably move into the Q&A, the 4 questions that we went through, just so we can put some things in line. First, I want to thank you and Dr. Peter Waswa for preparing this, and I hope that the audience got some of the answers that were part of the poll questions in this particular presentation. So if you please try and see if you can fix your internet accessibility. In the meantime, I'm going to share the results and then try and discuss them with Peter Waswa and you, so that the audience can try to relate to what you presented. So these are the results from the audience. Dr. Peter Waswa, I hope you can see them. Please go, if you can't, you can go to your poll question, the tab on your phone or a computer, and tap the poll quizzes. So the first question, Dr. Martha and Dr. Peter, is which of the following properties, which of the following are all properties, which of the following are properties of all cardiac cells? Select all that apply. So based on that, what is your take, Dr. Peter Waswa, from the presentation? We have 75% of the audience. We don't have complete 100% on all. So it seems some individuals did not select some of the options. So that means that there was a bit of doubt on whether all these are actually properties of cardiac cells. Over to you, Peter Waswa and Dr. Martha. Please unmute. You should be able to. Peter Waswa, are you there? All right, I'll probably just scroll through those. I think from her first slides, it was clear that automaticity, excitability, conductivity, and contractility are all properties of cardiac cells. And then the Dr. Peter Waswa, I hope you'll be able, please unmute yourself in case you can. In case you can, you should be able to. The next question is, normally the sun, that's a sinoatrial node, is the pacemaker because it has the shortest refractory period. 74% of the audience says true, while 26% says false. Dr. Pitawaswa? Martha, are you there? Okay, do not see them. And Dr. Pitawaswa is seemingly not there. So again, that one, I think Dr. Martha talked about it in a way, but the sinoatrial node has the shortest recovery time. And so that makes it the pacemaker. At least in the normal circumstances, it will be the pacemaker. The third question relates to which of the following is false about the AV node and electrical flow in normal healthy patients. And again, I'll just check in with the audience, with the chat group and see if Dr. Martha is there. I don't see her online. Peter Waswa, also not unmuting. Okay, so the AV node characteristics, which may not have been shared. The first characteristic is to do with, we are looking for something that is false. So only entry point from atria to the ventricle, that is correct. Only 19% of the audience said so. And then it's one way, and I think Dr. Martha mentioned that most of the electrical impulses that travel through the heart is one way. The AV node is one way to the ventricles, and the impulse cannot return except through another pathway in case of abnormalities. And then it has a delay, and I think that is also true. Because it needs to allow atrial contraction to allow ventricular filling at the end, toward the end of diastole. None of the above is certainly false. And of course, we are all here to learn in case you weren't aware of any of the options. And then number 4 is about the band of His and the Purkinje fibers have the fastest electrical flow in the entire cardiac conduction system. 86% said true, while 14% said false. And the ones that said true are correct. And this also explains why the QRS on the ECG is the narrowest. It's the shortest time period that we see when we look at the QRS period. It's about 120 milliseconds or less. And so it needs to be as narrow as possible to allow electrical impulses to be transmitted to both ventricles at the same time to allow contractility at the same time. I do not know if Peter Waswa is now on. You're still muted in case you're trying to answer some of these things. Let me check if Martha is back. Doesn't seem to be. Okay, so Dr. Rasmus, would you like to take on number 5 and number 6? If you're there.
Sorry, let me just stop on the audio.
Is the audio okay?
Hi, so I missed part of the talk by Dr. Lee because I went off as well. But yeah, so at resting state, which of the following is true regarding cardiac membrane permeability? So is sodium relatively impermeable? Is potassium relatively impermeable? Is sodium, sorry? Is sodium relatively permeable? Is potassium relatively permeable? And am I here to learn? So again, do we have our colleagues on board? I think this was a topic for Peter, and I think they're offline. So addressing membrane potential, there's going to be a little bit of a leak, or there's going to be an ongoing leak of potassium outwards, but it's countered by ongoing slow intake of potassium, sort of sodium to rectify, but there's generally a relative impermeability to especially sodium until the threshold is exceeded. So the people who selected option A, the 17% seem to have it here. Um, so potassium generally is not very much regulated um, uh, compared to sodium, which definitely will lead to depolarization. So sodium is only allowed in the cell when the cell is depolarizing after the threshold potential is exceeded. And then 6 is which of the following are factors that increase phase 4 depolarization. Phase 4 depolarization, remember, is the flat portion when the action potential is resetting to receiving potential ready to exceed the threshold and then fire again in phase 0. So in this case, you want to select all that apply. So if you stretch a muscle fiber, you can stimulate it for sure. If you increase the vagal tone, you're basically going to impair this process because you're going to cause hyperpolarization by opening potassium channels, and potassium will leak out of the cell. So option B should be wrong. Beta adrenergic stimulation should make it correct. Similarly, hypokalemia means that the sodium potassium ATPase pump reaches the resetting quickly, and so the patient should be triggering quite quickly. So that's why patients who are hypokalemia can be very tachycardic. So yes, options uh, options A, C, and D should be correct. But for sure, I am here to learn as well is correct. So I think that's my take on the questions. So Dr. Lynn Mather is back online, but I guess it may be a little bit too late for us to go through the questions again. So Dr. Cornelius, might you want to have a call before the next talk, or we just proceed? Over to you.
Yeah, I think we shall move into the next poll as we invite the next speaker. And the next speaker is also a resident and mentored by one of the fellows, and that is Dr. Jacob Nawezo, who is going to talk about electrophysiology of cardiac arrhythmias. Dr. Nawezo is a resident, I think, in Bara University. I could be wrong.
Dr. Nawezo is a third-year anesthesiology resident at Bara University of Science and Technology. Yes, and as we said before, our spirit here is to bring together everybody who's participating in caring for the critical ill. The Bara University crew has already become part of the team that presents on these days, and hopefully we shall be expanding to other institutions as well and other departments as time goes. So, Dr. Nawezo, kindly share your slides as Dr. Cornelius runs the next course. Thank you.
All right, so here is the next poll. We should also take about 3 minutes of this poll. And it has only 4 questions, 4 not very difficult questions, which we hope that you should be able to answer. And then we can have a discussion on them thereafter. Of course, the talk that Dr. Nawezo is going to give will cover some of the components in the poll, so you will get the answers as we discuss this, but we shall give you an opportunity to discuss this at the end. So far, 1 minute is down, and we have about 2 minutes to respond to the poll questions. Again, like the previous poll question, We have crossed 1.5 minutes, so we are left 1.5 minutes. Like the previous 4 questions, we have questions that have one most correct answer, and then those that have multiple answers that may be correct. So you select all that apply for those ones that have that have more than one correct answer that may be present. While some questions will have true or false, some will also have the option of I am here to learn in case things are a little tough. So don't worry, we shall have all the answers at the end of the talk. So we have about 30 seconds left to close this poll.
Dr. Cornell, the first question does not allow multiple.
It doesn't allow multiple. Apologies. We shall try and rectify that next time. Just select whichever you feel is correct, and we shall discuss the correct answers. Okay, I'm going to close the poll in a few seconds from now. Okay, that's the end of the poll. Dr. Nawezo, over to you.
Yes, good evening, everybody. So I'm called Jacob, and is a resident year 3 from Barry University. Well, electrophysiology of cardiac arrhythmias, what all that Dr. Lynn Mather has been talking about from the previous presentation applies here in detail. So all that we've learned from there should come also in this presentation. So that's just an overview of our heart, the superior vena cava, right atrium, the bundles. Yeah, that is from the synatrial node, AV node, into the east bundle, left and right. And into the Purkinje fibers. To understand the propagation and contraction of the cardiac myocytes and where they come from, we need to understand the concept of excitation contraction coupling. So we have the pacemaker cells and the contractile cells of the heart. And these cells are sort of connected together by highly sensitive gap junctions, by molecules called connexin desmosomes that allow movement of these action potentials. As you can see from here, we have an action potential coming in from, let me say, a pacemaker cell. And this basically, we can think of this as in the phase 2 phase and part of phase 3 of the contraction of the cardiac myocyte. So, and that's the part where we have an initial efflux of potassium, but also the beginning of entry of calcium into the sarcolemma. That's why there's some bit of sustainability in the phase part 2. So calcium enters into the sarcolemma, but then we get a concept called calcium-induced calcium release from the endoplasmic reticulum. And this allows further release of calcium into the cytoplasm. So when this happens, the calcium enters into the sarcolemma through these L-type calcium channels, as we've seen from the phases, and this triggers release of calcium from the endoplasmic reticulum into the cytoplasm. And this goes on to, this calcium attaches to other molecules. It can attach to calmodulin or to troponin. And once this attaches to it, that complex goes on to attach to tropomyosin that releases tropomyosin from the actin and then releases and exposes the binding site of actin and myosin, so that we have sort of a link up of those two, giving us a contraction. Yeah, so as the repolarization starts with a downstroke with further release of potassium from the cells, that's also about the time when the calcium are being taken up back into the endoplasmic reticulum, and the cardiac myocyte contraction ceases. So that is basically the concept of excitation, contraction, coupling, and this is enhanced by either effect of catecholamines, and catecholamines we know can be increased by either stress, by an infectious process, by an infection, and there's an effect of catecholamines on the L-type calcium channels. They further trigger further push of calcium into the sarcolemma, so that you have further triggering of calcium release and increasing inotropy of the cardiac myocyte. That is a bit of what we shall talk about later on. So when we come to mechanisms of arrhythmias, we have concepts of automaticity, triggered activity, which can either be early or delayed. Then we have a concept of re-entry mechanisms that we shall go into. So when you talk of automaticity, that is the ability of the heart to either increase or reduce its rate. So this can either give us bradyarrhythmias or tachyarrhythmias. And these can be stimulated by either the parasympathetic or the sympathetic nervous system. As we've noted that adrenaline has an effect on these. One, we see that adrenaline sort of causes stimulation, either adrenaline or non-adrenaline, so the catecholamines cause stimulation of the stimulatory G proteins that are coupled to the, so it helps to release cyclic AMP that goes and phosphorylates the calcium channels, causing release and thereby increasing the contraction, and also causing the increase in the heart rate. While we have parasympathetic, whereby we have the vagus nerve causing release of acetylcholine, that also instead it inhibits and causes prevents the release of the calcium channels through the L-type calcium channels. So if we look at this point here on automaticity, whereby we are having a slight increase in the upstroke of this is the sort of the pacemaker action potential. So this is the effect of a catecholamine release that increases the rate of the surge of the phanic sodium channels, and also the transient opens the transient calcium channels. Then further a drastic opening of the lab stroke. While if you look at this depolarization, this is a parasympathetic effect caused by inhibition of chemicals like acetylcholine. So this causes hyperpolarization. So the pacemaker cells become hyperpolarized in a way that there is a very progressive increase or opening of the phanic sodium channels, because the cells are initially already very negative inside. So you see that there is either going to be a bradycardia or a tachycardia, giving us either a slowed heart rate or an increased heart rate. Same on this side, it's just the same explanation. So when we talk of triggered activity, which we shall later on see that it's a mechanism for many of the ventricular arrhythmias. We have a normal, this is a normal action potential of the contractile cardiac myocytes. But then during the plateau phase, that is the contraction, we have a slight surge of, let me say, calcium ions causing an early depolarization, and yet the cell was going into a repolarization state. So this can be caused by a number of factors, such as, let's say you have continuous increase in calcium ions in the cytoplasm of the sarcolemma. So instead of the calcium ions progressively leaking out, it actually increases again. Or you have a patient with hypokalemia. Ideally, you need potassium to leaking out so that you get hyperpolarization. But anything that blocks that, then you'll have a limited amount of that, and you'll instead have an early after depolarization. Then we can have a triggered delayed after depolarization when your cardiac myocyte has almost fully repolarized. That is, you have gone through the second and third phase of the action potential fully. The cell has completely repolarized, but then you have in either the calcium ions giving us a delayed after depolarization. So we can see here we have a normal action potential. Then here you have a delayed after depolarization. This was because of pacing. And then this one is a sustained triggered activity because of continuous pacing. Then we have a mechanism of re-entry as a means of causing arrhythmias, and we shall have a discussion on that later on. So to understand re-entry mechanisms, we sort of have to have an idea of Koch's triangle. And this is basically a little bit of the anatomy of the AV node. So the AV node has is made out of about three parts. That is the anterior portion, the posterior portion, and then the middle portion. The anterior portion is made up of fast pathways, and the posterior portion is made up of slow pathways. So in a normal person, you have both, yes, the fast and the slow pathways, and you have an initial impulse from the atrium coming from the SA node, coming through the fast pathway. Then also a slow impulse coming through the slow pathway. But because this one is faster and enters through the His bundle, but also comes back and then cancels out the impulse from the slow pathway. What we have to understand initially is that we can make an analogy of the fast and slow pathway in form of, let me say, a dusty road and sort of another road, a dusty road that is very smooth and another road that is not really smooth. And we have two cars. So when a car goes through that smooth, dusty road, it leaves behind a lot of dust. Why I'm bringing this out is the concept of refractory period, whereby fast pathways take a longer time to get excited again compared to the slow pathways. So when the fast pathway when impulses pass through the fast pathway, they take a longer time to be excited again. So that's the analogy of a dusty road, and then you cannot go through it until it's fully cleared. While the slow pathway, as much as the car is going to go through, it doesn't leave any dust behind. So another car can just easily go through, although at a slower rate. So that means the fast pathway, as much as it's going to propagate impulses very quickly, it won't accept another impulse until it has fully recovered. Meanwhile, the slow pathway will take impulse very slowly, but it can easily accept another pathway. So when impulses reach the His bundle, then propagate into the left and right, some of them pass from here, as we can see, from here, and then it cancels out the slow pathway that was coming. That is ideally in a normal patient. But in case we have a premature impulse as noted in B by the asterisk, no impulse will initially go through the fast pathway because it's in a refractory period, which takes a longer time than the slow pathway. So our next impulse, which is premature, will pass through the slow pathway and go into the ventricles. It's going to have it depolarized. But some of it will also come back through the fast pathway. As it's coming back, now this pathway can accept another impulse. It has recovered. So this impulse will come back upwards, and then it can also excite the atrium. So you can see that it's going to be a cycle of depolarization of the ventricle, and also another one going to depolarize the atrium. So this gives us a re-entry mechanism, giving us an arrhythmia. Both the ventricles and the atrium are being depolarized. And that mechanism, you can see, is being shown in the schematic diagram in C. And we can see that this is basically the mechanism of most of the AV nodal reentrant tachycardias. So from what we've talked about, we can start going through a few of the arrhythmias. So we have atrial fibrillations. So this is just the atrium that is firing impulses from so many parts. And there can be factors that can trigger this out. Either you have re-entry mechanisms, or you have triggered after activity or increased automaticity. And underlying factors can cause this are things like stretch, and stretch can be from valvular heart diseases that is going to give an outpour back into either atrium, or an aging process that is going to cause scar tissue in a heart myocardium, giving you an area of a slow pathway and a fast pathway, giving you a reentrant mechanism. Or you're going to have spontaneous calcium release that is going to give you an early after depolarization or a delayed after depolarization. So eventually you're going to have an area on your atrium that is going to have ectopic beats. These beats are coming because of the irritation that is happening either from an acute stretch or a chronic stretch. So what you will have is, let me say, a reentrant mechanism giving you a tachycardia from both the atrium and also going on to propagate conduction in the ventricles. So let's say you have a normally functioning sinus atrial node giving impulses through into the AV node that is going to nicely pass through in a normal person and cause ventricular depolarization. But also you have ectopic beats, let's say around here on your left atrium, which is being facilitated by irritation or a stretch and myocarditis. So these are also going to give their own impulses that are going to come through the AV node. So you're having both impulses, many of them from the SA node and from these ectopic beats. Eventually, you can see the difference between a typical heartbeat on your left and one due to atrial fibrillations, whereby you're going to not have clear P waves because you're having impulses from ectopics just passing through here. And then the other thing is that you won't be having a regular contraction of the heart because you have spontaneously contracted in ventricle. So you have varying intervals of QPR intervals, as you can see. So this is sort of the mechanism of atrial fibrillations that we can think of when we talk of atrioventricular reentry tachycardias. We have the concept of accessory pathways. If you look at the diagram on your left, you have a normally functioning senoatrial node going through the AV node, one going through the Bachmann's bundle, back through the AV node into the His bundle, left and right bundles and Purkinje tissues to give you a nice P wave, QPR complex, and repolarization. Then when you have what is on your this, I don't know if you can see my sort of marker. So we have accessory pathways. This, I would relate this to a condition called Wolff-Parkinson-White syndrome. So you have an accessory pathway where you have an ectopic beat from somewhere passing through the accessory pathway, which is fast, then it comes back, it goes through the accessory pathway, depolarizes the myocardium on the ventricles, and then comes back through the AV node. This is not a normal conduction process. That's why you can have a cycle of events going through the AV node. So this is a mechanism of an accessory pathway. This whereby, so if you look at the Wolff-Parkinson-White syndrome, there are two types. That is the orthodromic type and the antidromic type. We shall explain this. So the antidromic type, you have the impulse coming through the accessory pathway, as you can see. It goes on and depolarizes the ventricular myocardium. But you can see that there is a sort of a delayed let's say upstroke of the QRS complex. It is not nice. You have like a delta, it's called a delta wave. So this is happening because the myocardium doesn't have the fast conduction as you could see in the His bundle. So the QPRS complex sort of delays in its contraction and gives you the delta wave. Then it comes back. So the pathway goes through the myocardium, then comes back through the Purkinje tissues onto the AV node and gives you that vicious cycle. Meanwhile, onto the orthodromic type of Wolff-Parkinson-White syndrome, you have the impulse going through the AV node. It goes through the AV node because it goes through the His bundle and the bundle branches, which has a faster depolarization compared to the previous antidromic type, the myocardium. So you won't see that delta wave. You will see a narrow QPRS complex, and then you will see as well the tachycardia. So the difference between these two is that the typical Wolff-Parkinson-White syndrome, we have a slight upstroke, as you can see, of the QPRS complex because of the delayed slow depolarization of the myocardium because of the slow conducting fibers. Then the white QPRS complex because of the same and the short PR interval. So this is a necessary pathway where the impulse goes through an area that is not in the AV node. So when we talk about this other type of re-entry tachycardia, it's the atrioventricular nodal re-entry tachycardia. So if we picture the re-entry pathway of the slow and the fast pathways, we have sort of an impulse in this type of arrhythmia. It's both the atypical, we have the atypical and the typical AV nodal re-entry tachycardia. So a typical finding on ECG on the typical AV NRT, which most times is what we shall find, the slow fast pathway in about 90% of cases. So we have that the P wave is sometimes coming in, it sort of gets embedded in the QPRS complex, or at worst it comes, it presents itself as a pseudo S or a pseudo R, depending on the leads you're in, either lead 2 or lead V1. And this happens because when you're having impulses, these premature impulses coming through the slow pathway, it's sort of, as much as it's going to depolarize the ventricles, it goes backwards through the faster, now being able to excited fast pathway, and gives you a very quick P wave, which sometimes is embedded in the QPRS complex, or it just comes a little bit after the QPRS complex. And it is, as you can see, it is being noted as a pseudo R wave when you see in lead V1, or a pseudo S wave when you see in lead V1. So this is a typical presentation of an atrioventricular nodal re-entry tachycardia of the typical type, which when you see on an ECG. While the atypical type, you have, instead of the slow fast mechanism, you have a fast slow mechanism. And sometimes this P wave comes because of focal ectopic beats happening in the atria. So the other
Jacob,
Yes?
You have 5 minutes.
Okay. The other type of supraventricular tachycardia is atrial flutter, and this is mainly because of a macro entry circuit traveling around the tricuspid area, the area between the IVC and the tricuspid valve. So it's sort of the same entry mechanism that we have talked about, and it can either be a clockwise or a counterclockwise mechanism. And this gives us positive flutters in the inferior, positive flutters in the lead 1, 3, or AVF. And this, we have an atrial rate of between 300 beats and ventricular rates of around 150 beats. You can see the sort of a sawtooth appearance of the flutters you can see. Then ventricular tachycardias, this is basically focal. It can either be focal from one point or multifocal from varying points on the ventricles. We know that the ventricles have a pace of around 30 beats per minute, but because of the same irritation that is happening, you have faster beating. So if it's from one area, we have monomorphic VTACs. If it's in many different areas, then we can have polymorphic ventricular tachycardias. The torsade point is just twisting around the points, and this we see that the early after depolarization mechanisms contributes a lot to the torsade points mechanism of ventricular tachycardias. Then we have fibrillations, is just almost the ending point of a dying heart, and it moves through it moves through ventricular flutter, ventricular fibrillation. It moves through a ventricular flutter, then you go into ventricular fibrillations. When you have a flutter, it's almost the same, but happening in the ventricles. So in fibrillation, it's just quivering of the heart. There is no clear ventricular depolarization. So all you have are these just contractions that clearly do not give you any push of blood out, and this amplitude becomes fine and smaller as the heart eventually dies out. Thank you.
All right, thank you very much. Doctor, you can stop sharing your slides so that Dr. Preach can also share his 2 slides, and then we shall go into a quick Q&A. In case you have any questions, please post them in the chat so that the presenters can be able to respond to them as soon as possible. Dr. Preach, over to you.
Thank you very much, Dr. Dr. Cornelius. So I just have a summary. So the first thing is cardiac arrhythmias while playing, and then the take-home message. Next here, this was a tweet by Ryanair. I found it quite funny, whereby this colleague is carrying Poland, is carrying France, and Belgium and Germany are going home. Now, this cardiac arrhythmias in playing specifically applies to our colleague who is carrying Poland. I've been unable to mention his name. It's very complicated. And the cardiac arrhythmia that can happen in them is called commotio cordis. So basically what this happens is that you have a ball. Let me get a pointer. Perfect. So you have a ball that comes and hits your heart, your chest, basically near your heart. And this creates a very big pressure, rapid rise in intracavitary pressure. Now, if this unfortunately happens within the 20 millisecond window of the upstroke of the T wave, immediately you end up having ventricular fibrillation. And the exact mechanism is the early after depolarization, because at the upstroke of T, we are still at the plateau phase. That is stage 3 of the action potential wave. So if this happens, it can happen. Of course, commercial cordis is more common in pediatrics and young children because they don't have very thick skin. Therefore, any ball can hit them. And again, it's very common in small balls, hockey, lacrosse, baseball, and a fist or a blow. So we shouldn't hit our friends on the chest. The football, which is currently happening presently, it's quite big and has air. Therefore, the impact is not so much. However, it is something to think about, underpinning the importance of having paramedics around major sports, because of something like this can happen. Now, the take-home message from what Dr. Jacob has presented, it's threefold. Number one, re-entry arrhythmias have an abrupt onset and offset. Therefore, when you're taking a history, they will tell you, doctor, I was here, and then suddenly the heart rate picked up. That's very important. Enhanced automaticity, they have a warm-up and cool-down phase, meaning gradual increase and gradual decrease in arrhythmia. So it's not very fast. It's important to remember. Then triggered activity arrhythmias can be caused by mechanical injury, as I've explained, such as a blow to the chest, or in patients with a prolonged QT syndrome. For example, if someone has a very terrible sinus bradycardia and the QT segment is very prolonged, such patients occasionally can end up having a triggered early after depolarization, and they end up with an arrhythmia. Thank you very much.
All right, thank you very much, Dr. Preach. And then let's quickly try to go through the electrophysiology. The results of the poll questions, of the 4 poll questions, I will request Dr. Jacob and Dr. Preach to try and respond to them. So the first one is, arrhythmias may be caused or characterized by which of the following? It was a multiple correct answers. Unfortunately, the audience wasn't able to select the correct answers in their multiplicity. So let's start with abnormal rate. Is that true or false? Jacob?
Abnormal rate, I think it's true, because you can either have reduced automaticity or increased automaticity. You can have a bradyarrhythmia or a tachyarrhythmia, which is, I think, part of the arrhythmias. So, yeah.
All right. What about abnormal regularity?
That's also correct, because let's say you have what's happening in atrial fibrillations, whereby you have both conduction happening in impulse from the SN node and also from the ectopics from elsewhere, and they're having varying times at which they are giving impulses to the ventricle. So you're going to have irregularities. So it's correct.
All right. Abnormal impulse origination?
That's also correct, because you'll be having the ectopic bits coming in, or the triggered after activities. So yeah, I think.
All right. And then abnormal conduction, I think, is what you actually talked about with like Wolf, Parkinson, White. All right. And then principal mechanisms associated with tachyarrhythmias include all except, sorry about the spelling there. So this was looking for the false mechanism. So the first one, suppressed automaticity, Jacob?
Suppressed automaticity, that's correct.
Okay, and then re-entry? I think you mentioned that in the last one. Yeah, and then triggered automaticity. I think that I think you could relate that to some of the components you mentioned. I know you mentioned triggered activity, automaticity, and reentry, which still falls within all these categories. The least correct answer of these is excitability, and that's the one that just a small fraction of the audience selected. Then the third question, Dr. Preach, most common cardiac induction abnormality. I think it's supposed to be conduction abnormality leading to arrhythmias is reentry. Is that true or false?
That is very true.
Okay. And then the final one, Dr. Preach, a polymorphic ventricular arrhythmia, especially associated with prolonged QT intervals, possibly induced by early after depolarization, will include which of these? SVT, the supraventricular tachyarrhythmia, and then Torsades de Pointes, both or neither?
So here I would go with Torsades de Pointes because supraventricular tachyarrhythmias, there are very many, and you don't know which one they're talking about. So Torsades de Pointes is the most appropriate answer here.
Okay, thank you, the two of you, for the submissions and for the presentations you've made. We are going to move to our last presenter, Dr. Matovo Andrew, who is a third-year resident in emergency medicine, and he is going to tell us about antiarrhythmic drugs. We shall give him approximately 15 minutes to try and wrap it up, to give us an overview of these drugs. But just before he does that, we shall take 2 minutes to fill out this poll on antiarrhythmic drugs, which has 5 questions. So answer as fast as you can. We are aware of the time that we have with you, and it is limited, as well as your need to go and enjoy the World Cup. So please try and respond as much as possible. Okay, we have about a minute left. So if you could try and respond as quickly as possible, we should be able to get your responses as soon as the 2 minutes is up. Okay, we have about 20 seconds left. Okay, we are done with the poll question. I will allow Dr. Matovo to proceed, and then we shall discuss this at the end. Dr. Matovo, over to you.
Good evening, everyone. I hope I'm audible to everyone online. Am I audible?
You are audible and we can see your slides. Please proceed.
All right. I'm going to be talking about antiarrhythmic drugs in this presentation. In my outline, I intend to briefly talk about the action potentials in the different cells of the heart. That is the nodal cells and contractile cells, the non-pacemaker cells, because this will be very important when we're talking about different drugs, because different drugs have different activities and different cells. So you find that some drugs will have the activity on the nodal cells. Then we shall also have some drugs having the activity on the non-pacemaker cells. I'll look at the classification of the antiarrhythmic drugs. I'll briefly try to go through the detailed pharmacology from different classes, and we shall be ending the session. So it is when talking about antiarrhythmic drugs, it is important to know how they bring about their effects, how they control arrhythmias. Different drugs will act to bring about control the rate, that is the conduction through the nodal cells. In this particular case, I'll take the pacemaker cell being the AV node, whereby impulses are coming from different sections, maybe from the atria, maybe coming from within the normal conduction pathway, passing through the AV node and then going to the ventricles. So we shall have drugs that work at the AV node to control the rate of transmission of these impulses. We shall also have drugs that work at different contractile cells that might be irritated and giving up impulses or giving up action potentials, as we've seen from the different mechanisms, like from a triggered activity. There could be a triggered activity in a atrial cell or a ventricular cell that is irritated and is firing. Then the impulses are conducted to different cells, then through the conducting system throughout the heart. So it is important to look at the action potentials in different cardiac cells. So this particular graph here, it shows the action potentials in the pacemaker cells. In this particular discussion, let's take this to be an atrioventricular nodal cell. So as we see, we talked about what happens. It has about 3 phases, that is phase 4, phase 0, and phase 3. And we shall find that some drugs will work to alter the activities in phase 4, others will work to alter the activities in phase 0, and some will work to alter the activity in phase 3 of the action potential curve. It is very important. How do they do this? What the drugs do, like for example, in this particular pacemaker cell, you might find that they work at phase 4 to increase the duration, to increase the slope, the time taken to get from phase 4 to phase 0, and thereby decreasing the action potential, increasing the time required to make an action potential. So other drugs will work at phase 0, in this case, where we have calcium influx, the L-type calcium channels opening this phase, as the previous speakers talked about, blocking them and thereby decreasing the slope of this decreasing the slope of the phase 0. Others will work at phase 3, which is the repolarization phase, where we have efflux of calcium, of potassium out of the cell. Potassium is getting out of the cardiac cells through the potassium channels, and thereby some drugs will work at this point to block that potassium channel and thereby exerting their effects. It is also important to note that there are these drugs that we talk about work at different phases and they work through different channels. You find that at phase 4, where we have the T-gated calcium channels, some drugs will work there. And also at phase 4, we still have the inward sodium channels, which they talked about, that allow the infusion of sodium into the cell. Some drugs will alter that phase, increasing their duration. Others will work at the 0 phase, where we have the voltage-gated L-type calcium channels, blocking them and altering their action. That is in the pacemaker cells. It is very important to note. So the pacemaker cell in this particular discussion, let's take the AV node to be the pacemaker cells. So the pacemaker cell, the AV node, we know that it is the gateway between the atrium, impulses coming from the sun, the atrium, into the ventricles. So if we get drugs that can block or depress the activity of the AV nodes, so we shall be able to control the firing of action potentials from the different dysrhythmias that are above the AV node through the AV node to the ventricles will be controlled. We shall look at them. So here are the non-pacemaker action potentials. This is this graph here shows the action potential in the non-pacemaker cells. Let's say it's a ventricular myocyte, it's a atrial myocyte that is agitated. So we see that phase 0, as we talked about it, where the action potential is starting, the inward sodium channels allow sodium influx to bring the threshold from resting membrane potential to the threshold potential. So we shall have that phase 0, a sharp rise, which shows the action potential, whereby the voltage sodium channels are opening to allow the influx of sodium to depolarize the cell, and we shall have a sharp upstroke. Some drugs will be working at this particular point, the sodium channel receptor, the voltage-gated sodium channel receptor, by blocking it either blocking it such that the slope is delayed. They reduce the conduction velocity through that sodium channel. When we look at phase 1, where we have early opening of the potassium channels to allow efflux, the first phase of repolarization, to allow efflux of potassium, still you shall have some drugs that work at this sodium, at this potassium channel, blocking it, preventing the efficient efflux of potassium from the cell outwards, thereby affecting repolarization. And it's affected in one way or another. It's affected in increasing the duration. Once the sodium channels are blocked, you find that the duration is increased for repolarization. That's why you'll find that at the end of repolarization, there is an increase in effective refractory period, the duration, and the overall action and potential time is also increased. That's how they work on that. We can have some drugs that can work at the calcium, at the calcium channels. That is at the plateau phase, where we have both influx of calcium and efflux of potassium to provide that plateau balance that we see in the during refractory period. Till the phase 3, where we won't have any more influx of calcium through the L-type calcium channels, and only have continuous efflux of potassium to bring back the curve to the resting membrane potential at channel 4. We have different drugs that work at these different receptor points that are represented by the different phases in the graph. It is important also to note that in a non-pacemaker cells, here the main target of these drugs is to control the rhythm. We know that in the non-pacemaker cells, we're trying to control the rate. But now in the cardiac cells, we're trying to control the rhythms, because we know that cardiac cells are the fast conducting action potential tissue. So once we allow them to fire, they'll fire way above the sun, which is the slow conducting, the sun and AV node, which are the slow conducting action potential tissues. So they will definitely provide a dysrhythmia. So here our worry is to deal with the rhythms, while we're talking about the contractile cells or the non-cardiac pacemaker cells. So we shall have, I'll try to look at the classification of these different drugs. There are different classifications that are out there. There are some classification. I here use the Vangar-William classification. It's the ancient one. However, there is a classification which also has class 0. Class 0 is either drugs like the example that I came up was ivabradine. It's a new drug. It's a new drug, and for it, it's used to control usually tachycardia or arrhythmias, tachyarrhythmias, especially this time tachycardia that is arising from the sun, where the arrhythmia is within the normal conducting system, but it's a tachycardia, a sinus tachycardia. These ones, I didn't talk about them much here. So the Van Wert classification classifies the antiarrhythmics into 4 main classes, but I'll talk about the 5th class, which is miscellaneous in this group. So the classes, there's class 1. These are mainly potassium channel blocking drugs. Then we have class 2. These are the beta adrenal receptors, the beta blockers. We have class 3. These are the potassium channel blockers, which are the examples, the miodarons and so on. Then we have the class 4, which are the calcium channel blockers. All of them work to control arrhythmias. So if we to look at maybe what we're looking at, whereby we're looking at the rate control and the rhythm control. From the curves that we've been seeing, we find that from the pacemaker curve that we saw, which has 3 phases, phase 4, phase 0, and phase 3, where the drugs that will be working at that category, we shall have drugs that work at phase 4, drugs that work at phase 0, where the L-type calcium channels are opening. That means we shall have class 4 in the rate control group. Then we shall have the beta adrenal receptors also will work in the rate control group. Then we shall have the other drugs that are part of the class 5, like adenosine, digoxin, also working in the rate control group. If we to go to the other side of the rhythm control group, whereby we're looking at the the non-pacemaker cardiac cells, we're trying to look at drugs that alter all the 4 phases. That is a phase 4, phase 1, phase 4, phase 0, phase 1, phase 2, phase 3. So in phase 0, in the non-cardiac cells, we saw that the voltage-gated sodium channels are the ones open. So we shall want to get drugs that are targeting the sodium channels. And here we see class 1 are the drugs responsible for the blockage of the sodium channels. So in the rhythm control, we shall want to put the class 1 drugs. We see the class 3 drugs, that is the potassium blocking channels. We see still in that graph of action potentials of the non-cardiac cells, we see that potassium is effluxing from the phase 1, where there is early repolarization, where the early efflux of sodium channels, so to block that. In the plateau phase, it still has some role, since there is influx of calcium, but also efflux of potassium. It shall be blocked at that level. And phase 3, where we shall have repolarization, complete repolarization, where there's only efflux of potassium, it will also be blocked there. So we shall find that the drugs that are in the rhythm control group are class, that is class 3 and class 1. However, we can also have class 2, the beta blockers, have an action still on the non-cardiac myocytes. So it is also important, so it is these drug actions, this I have already talked about, they will work to decrease decrease phase 4, the slope of phase 4, which we talked about. Then also some drugs shall be seen to raise the threshold potential. That is, we shall see some drugs like adenosine and digoxin. They do cause hyperpolarization of these cardiac cells, and they lower the action potentials, the membrane potential below the resting membrane potential. If we say like in an arterial cell, the resting membrane potential is at -70, these drugs will hyperpolarize the cell, take it lower, say to -80. So it will take more time for that cell to reach the threshold potential for depolarization to take place. We shall talk about them more in details. We have also some drugs that reduce the conduction velocity, that is the alter phase 0. They work on if it's in a non-cardiac cells, they'll be blocking sodium channels. If it's in the cardiac cells, they'll be blocking the L-type calcium channels, altering the phase 0. So we have drugs that also increase the effective refractory period. Those are drugs that usually block the potassium channels, whereby if the action potential duration from phase 0 to coming back to phase 4 was to take 100 milliseconds, then you will find that it will take about 120 milliseconds. Just it's not the correct figures, but just understanding what I'm talking about. So I'll start with class 1. The class 1s, we talked about them as being sodium channel blockade. These ones have a varying degree of blockade of the sodium channel, and that's why they're further sub-classified into 1A, 1B, 1C, each with varying strength of sodium channel blockade. We shall have the class 1C having the most strength at blocking the sodium channels, then followed by class 1A with moderate blockage of the sodium channels, and the least blockade of the sodium channels happening with class 1B, where we have examples like lidocaine. We shall be seeing the different examples in the different groups. So here we have a graph showing the action of the different drugs on the action potential curves in the non-cardiac myocytes in this case. If we say like drug 1A, its action is to prolong the action duration. If we look at the curve, we see that we still, I think everyone can name the phases, yeah? We see that from phase 0 coming to phase 3, the red curve is the curve that shows the red curve. This is the red curve is a curve that shows the red curve that shows the effect of the drug when the drug has been applied. So when the drug is when the sodium channel blocker, in this case we have we could have different examples where in class 1A we have procainamide, we have quinidine, disopyramide. Those are the drugs that are usually common there. So what they do once they block the sodium channel, the voltage gated sodium channel in phase 0, so there will be a flux of there won't be influx of sodium into the cell. So we won't have this sharp rise in phase 0. So you see that it's a slight depression of the phase 0, which we see marked as the yellow curve away from the normal one, the no drug zone. So we see it's depressed in one or another. It's not opening at a very fast rate. And these ones have a moderate blockade of the sodium channel while carrying out their activity. However, important to note, the class 1 drugs importantly increase the slope of the refractory, the phase 3 slope, which is the calcium efflux. So what does this mean? Whereas they have an phase 0, that is the sodium influx blocking it, they also have a minimal effect on the blockage of the potassium channels, thereby prolonging the refractory period and the general action potential duration in general. That's why you see the red, the curve with the drug is shifted more to the left. So it's prolonging the action potential duration, thereby increasing the effective refractory period. It's prolonging it. These drugs have one effect that we shall see, is that all the drugs that actually have an effect on blocking the efflux of potassium and increasing the effective refractory period will end up increasing the QTE interval, as will be seen on the ECG. So when we go to the class 1B drugs, usually have the least effect of blockage on the sodium channel. So we shall have a minimal depression of the slope of the sodium channel, as we see phase 0, where the blockade of the sodium channel the voltage gated sodium channel is taking place. It will be minimal. However, they also have an effect that you can see the yellow curve in the column of B, that drugs the refractory period to the right side. They decrease the refractory period, the effective refractory period. That's the difference we can see. Where I read they produce this effect because they're able to block the sodium channel both in its activated and inactivated phase. That's why they have that effect of decreasing the effective refractory period with a minimal effect on the phase 0. So these are the drugs you'd want to use in arrhythmias associated with a prolonged QT interval in this case, because they're able to reduce the overall action potential duration, the effective refractory periods. So these drugs are, we shall say examples, that's lignocaine, the local anesthetic. So the class C drug, let me see. So the class C drugs, the class C drugs have no effect on we see the class C drugs have no effects. They have the most effect, they have the most effect on the blockage of the sodium channel. They have the most effect. So they block the sodium channel strongly more than any other drug. So the order of sodium blockade is C, A, B. So it can be CAB if to get the mnemonic CAB. So these the group C drugs will depress it further. They affect phase 0 mostly. So they depress the phase 0 mostly.
they have little or no effect on the refractory period. So that's why you see the red curve is almost ending at the same, the phase 3 curve is ending at the almost at the same point as the normal curve with no drug. So if we to look at the sodium channel blockade, we have the examples. We have procainamide, you have disopyramide. Okay, that name is hard. Quinidine, these are the drugs we have. Procainamide is one of the most common ones. So if we to look at the quinidine in particular, it has its cardiac effect is membrane stabilization. We can produce ECG changes. That is prolongs the QT interval, as we saw. It prolongs the QT interval because it increases the effective refractory period and an overall action potential duration. It has an effect of widening the QRS complex, as we saw, because of the increased length of the effective refractory period. It also has some anticholinergic effects, that is, but most pronounced in the disopyramide type, the example. So they also have adrenergic blocking effects, can cause also vasodilatation. The clinical use that has been used with quinidine is atrial flutter and atrial fibrillation. So you're trying to cardiovert, because these drugs are, since they're working at the myocyte level, at the non-pacemaker cardiac cells, they are to control that rhythm, the cardioverting. So they're having the chemical cardioversion effect. They are also used to maintain the sinus rhythm after cardioversion. You convert them into a sinus rhythm, you want to maintain them so that they don't tip back into a dysrhythmia. The adverse effects, quinidine has a syncope, quinidine syncope or fainting due to study points. This is looked at since they increase the effective, those study points, since they increase the effective refractory period, that is increasing the overall refractory period. They're taking long before the cell can depolarize again, putting this patient at risk of early after depolarization, which can further tip them into torsade points. We have, they can cause hypotension as one of the adverse effects. These are as one of the adverse drug effects due to their negative inotropic effects. They can be given orally or rarely IV. This is for quinidine. For the procainamide, also the pharmacology is less toxic to the heart. It has no anticholinergic effects. It's more effective for ventricular, and it's more effective in ventricular than atrial rhythms. I cannot explain why. Some of the adverse effects, it's studied to cause low path-like effects, the drug-induced SLE. Most of these drugs can cause hypotension because of the negative inotropic effects. To start the points, so since they increase the effective refractory period and the total action potential, they are usually used in the emergencies, the procainamide. Other example is the disopyramide. So we have the class 1B drugs. These are the drugs that we saw that have a very minimal effect on the phase 0, that is the blockade of the sodium, but also have a very good effect of reducing the effective refractory period. So these are drugs that you want to use in arrhythmias associated with a prolonged QT interval. So their main their therapeutic uses is that they use them in arrhythmias, in surgery. It can be used following myocardial infarction. It can be used following myocardial infarction. You are effective in treating emergency ventricular arrhythmias. The pharmacokinetics of lidocaine, it is not effective in atrial arrhythmias. It has a reduced bioavailability. It has the half-life is about 2 hours. Some of the adverse effects is hypotension because of the negative inotropic effects, and of course, similar to other local anesthetics, it can cause lust. The lust, that is, we can have seizures, we can have tinnitus, dysrhythmias, tremors. Some of these drugs can cause that. Mexeletin is another example in this category of drugs.
And it has a prolonged half-life of up to 10 hours. It causes all these that we can see: nausea, vomiting, drowsiness. Yeah. So class C drugs. Here we have the flecainide, propafenone, and some others that are found in this class of drugs. So it has no effect on the action potential duration, as we saw from the curve. It suppresses the upstroke of phase 0. That is, the sodium blockade is the strongest, as we saw. So it can be used in supraventricular tachycardias. It can be used in WPWs. It is very effective in ventricular arrhythmias, but there is a risk of proarrhythmias. Important to note, most of the drugs of antiarrhythmias have the ability to cause arrhythmias themselves. That is very important to note. So you can only use them when the need outweighs the risk. So it is important to note. Some of the adverse effects that we saw, if they are proarrhythmic, as we talked about, they can cause lust with their CNS effects, as we see, dizziness, tremor, blood vision, abnormal parathesias. They can worsen heart failures due to their negative inotropic effects. Since you don't want to give these drugs to a person who is already having a failing heart. So you don't want to control arrhythmias with such a drug in a person with a failing heart. So the other class that we looked at is the beta. There's a class 2 antiarrhythmics, and these are the beta blockers. Beta blockers, we saw that we can use them in the category of rate control because they can suppress the AV node. So beta blockers receptors, they reduce the sympathetic effect on the heart. So how do they do this? We know when you have the sympathetic system is working, you have the beta 1 receptors that are stimulated. So when the beta or the catecholamines are stimulating the beta 1 receptors, these beta 1 receptors are attached to G proteins, the G stimulatory proteins. These once activated will go on and activate the adenyl cyclase, that is the adenyl cyclase, which will then transform ATP, reduce ATP into cyclic MP, which will further go on to stimulate protein kinase, and protein kinase will phosphorylate the L-type calcium channels that is in the phase 0. Once they are phosphorylated, they're activated. We shall have influx of calcium and calcium into the cell, and there we shall have depolarization, phase 0 in the cardiac cells. So what do these drugs do? They block off that activity. They block the beta 1 receptors. That won't happen. There will be less phosphorylation of the L-type calcium channels. In the long run, little calcium will enter, and that will depress the slope of phase 0. That's how they exert their activity. So they are good in rate controlling. So their therapeutic uses, they can be used in atrial arrhythmias associated with maybe thyrotoxicosis. Or they can also be used in in WPW arrhythmias. They can also be used in digitalis-induced arrhythmias. We shall look at how this. The examples we have is esmolol, which is the IV form. Some of these drugs are very hard to find, but in that institute they're there. Then we have the outpatient category, propanolol, atenolol. It is important to look out for some of the side effects these drugs might cause. They are beta blockers, because we know what beta blockers do. Once if you use a beta blocker, then you definitely blocking the AV node conduction. That's what they do. That's how they exert the activity. So you have to watch out for heart blocks that might result due to that. You have to watch out for bradycardia. They can tip someone into failure, since they all definitely have a negative inotropic activities. They could throw you into hypotension. If they used probably other beta areas in the respiratory system, they could lead to bronchospasm. So you have to watch out for some of those. The esmolol in particular have a half-life of around 9 minutes, very short acting.
Andrew?
Yes, doctor.
3 minutes to wrap up.
Okay. All right, so we have class 3 drugs, that is amiodarone, sotalol, and others. These drugs are potassium channel blockers. So they block the potassium channels from potassium channels are both in phase 1, that is in non-cardiac cells, phase 1, phase 2, phase 3. So they block them at all levels. The overall effect is increasing the total action potential duration and the effective refractory period. So these are drugs that will increase your QT interval. So amiodarone is the most common, is what I'll talk about. So it prolongs action potential duration, prolongs the refractory periods. Its main action is controlling efflux of potassium, however, it can also work on other receptors. That's other channels. That's what amiodarone does. It can block the calcium channels, can block the betas, and even class 1A. It is mainly used in resistant ventricular arrhythmias to maintain sinus rhythm. It can also be used in resistant supraventricular tachycardia. I think this one has the biggest role because it can almost be used in both atrial and ventricular arrhythmias. However, it has a myriad of side effects that we really know. It can cause a bradycardia, heart failure. It can cause a pulmonary fibrosis. It's known to cause interstitial lung diseases. It can cause hyper or hypothyroidism. It has iodine in it, so it can easily cause hyperthyroidism, but can also directly cause harm to the thyroid glands, causing hypothyroidism. There are bluish colorations which are usually deposited in the skin and sometimes in the cornea. It can cause hepatotoxicity, so it is important to monitor your patients. So LFTs, thyroid function tests, you have to monitor these patients. In the pharmacokinetics, it's metabolized by the cytochrome P4. Okay, those 3F4 and 2C8. That means you have to watch out for drug interactions. Some drugs like rifampicin induce and might affect its activity. Others prolong and might cause more side effects like metoclopramide and some other antiemetics. So this is what I've talked about. So yeah, this is another class that is the class 3 butylide. It's an example that is used. It causes a QT prolongation that we talked about. Sotalol is another example in that group. Sotalol prolongs the duration also of action potential like the others. It suppresses phase 4 of spontaneous depolarization. It has a beta-adrenergic blockade activity. It might also induce polymorphic Torsades points, as we talked about, that most of the drugs that increase the effective refractory period increase the QT. So those that increase it put you at the risk of early after depolarization and thereafter Torsades points. So the class 4 drugs are the calcium channel blockers. These ones, we prefer the non-dihydropyridine family, as the other causes vasodilatation and a dip in BP. So the examples we use here, diltiazem and verapamil. So these worked, we target them we look at them mainly at the cardiac cells. So where would we find the calcium channels? In the cardiac cells, that is in phase 4, and more importantly, in phase 0, where the L-type calcium channels open from. So they block them, go on blocking them. In the long run, they will affect the slope of phase 0 and also mildly affects or no effect on the effective refractory period. So that is verapamil. The other class that I want to talk about is the class that is considered as the class 5 is adenosine. Adenosine works by acting on the adenosine receptors. That is adenosine receptors on the heart, on the myocyte. It is coupled on a GIP inhibitory protein, which has its gamma subunit, which will go on and activate the potassium channels, yes, leading them into hyperpolarization. Once adenosine attaches to its receptor, it's attached to it's coupled to a G protein, which will cleave into its gamma subunit, which will go and activate the potassium channel, making it leading to a strong efflux of potassium out of the cell, and this will draw them membrane will lead to hyperpolarization because it will lead to electronegativity of the cell way below its resting membrane potential, and this will take more time for the cell to be activated from its hyperpolarized state to a threshold potential to trigger off an action potential. That's how it exerts its activities. So its therapeutic uses, it's the most common drug we use in SVTs, whereby it has a very short half-life. So like you use it to control, but you cannot use it in, you can use it, but it won't have a good effect in, say, atrial flutter, atrial fibrillation, as it has a very short acting duration. So it's better for SVTs. Its adverse effect is flashing. It has a vasodilatory effect. That's why it will go to the skin capillaries, vasodilate them, and then you'll have that flashing, and very many others. So here we're trying to look at how some of these drugs can be used to talk. Yes, doctor.
I'm
I'll
sorry,
stop here.
I'm going to stop you, and then we do the quiz.
Okay, doctor.
This
This was my last slide. This was my last
all right.
slide.
I think let's just go into the quiz, and then you can respond to that, and then we shall hand over to Dr. Erasmus to wrap this up. All right, so these are the poll questions for the quiz, and I hope they were fairly easy for the audience. So the first question here is: many antiarrhythmic drugs are also proarrhythmic. It was a true or false. 92% of the audience says true. Andrew, your thoughts?
Yeah, that is very true. It's very true, doctor.
Okay. Any extra rationale as to why that may be true?
Most of these drugs have a very narrow therapeutic window. So above it, they can trigger arrhythmias. Yeah.
All right. And then in case of tachyarrhythmias, when in doubt, use amiodarone. Is this true or false? 86% of the audience says true. 14%.
Yeah, I think it's true.
It's true. Okay. And then the classification that you have just told us about of antiarrhythmic drugs misses out, at least the original one, misses out many antiarrhythmic drugs. Is that true or false?
Yeah, I think it's true. The Van Gaal-William classification only looks at class 1 and class up to class 4, but we realize that there's class 0, the ivabradine, and then class 5 where we have adenosine and digoxin. So I think it's true.
Okay. So which drug is the least appropriate for managing SVTs of these? Lignocaine, beta blockers, adenosine, digoxin.
I think it's lignocaine in that.
Okay, so we should more or less limit lignocaine to VTs and not SVTs. Okay, which drug is the least appropriate for managing VTs of these here? Lignocaine, mexiletine, procainamide, and digoxin.
For managing what? VTs?
Yes, VTs.
Yes, are the examples?
Least appropriate, lignocaine, mexiletine, procainamide, and digoxin. Those are the options.
I think digoxin.
Yes, I would also go with digoxin. All right, I think that wraps up the talk for the day. Dr. Erasmus, I hope you're there. I would like to hand over to you for the wrap up and then close the session. Dr. Erasmus doesn't seem to be with us. Or maybe he's...
Cornel, I'm here, but it says that the host is not allowing us to unmute.
Oh, okay. Let me allow you to unmute. Sorry. It was the audience that I wasn't allowing to unmute. All right. You unmute. You can unmute yourself. And
thank you so much, Dr. Cornelius, for moderating, and to our presenters, a big vote of thanks to you guys for doing a good job. You know, basic science becomes very annoying as we grow older, especially in the profession, and yet it is the foundation of caring for the acutely ill. it is probably all you need sometimes to care for an acutely ill person. So I'd like to deeply thank our presenters, Dr. Lynn, Martha, Dr. Jacob Nawezo, and Dr. Matovu Andrew for coming up with these talks and doing a good job to share all the science with us, especially in a way that most of us would understand and keep. Also to the mentors for doing a good job keeping these guys on their toes and just coming up with good stuff. So thank you, Dr. Preach, Peter Waswa, and Claire. So this lays the foundation, as I said earlier on, to what the rest of the stuff are going to cover in cardiovascular medicine before we switch to something else. So I hope that we'll be paying attention so that we can relate to a number of things as we turn to the clinical application of all this. So next week we shall be tackling supraventricular arrhythmias, and this I'm hoping that you come in a lot of questions, but more important, go and read so that whatever is spoken of here is not news, but only serves to perfect your understanding of the subject. Thank you so much for all your time, and I wish you a great weekend till next week. Bye-bye.